Good evening. Welcome to Marian University, the 6th annual Dr. Darrell A. Treffert lecture series on autism. And this year's topic is Help is on the Way, and we have very special guests. But before we start, let us bow our heads for a moment of silence to pray for the victims of the Boston Marathon bombing. Before I introduce you to Dr. Treffert, who doesn't need an introduction, I'd like to acknowledge some people here who, this event is sponsored by Kappa Delta Pi, Alpha Delta Theta chapter, and I'm the chapter counselor. My name is Aida Miklowski. I'm also a faculty in the School of Education. Our Dean of the School of Education, Dr. Stoddard, is hiding behind over there. And then we have some faculty here, and the Sisters of St. Agnes, Sister Mary, Sister Donna, who else, and some top banana somewhere over there. And I would like to give a special thank you to Kit for the technology help and Donna Rogantin for all the facilities help. And thank you all for coming. And without further ado, Dr. Treffert, who doesn't need any introduction, everybody knows him. Okay, thank you.
Thank you, Ida, and thank you for coming this evening. And thanks to Marian and the School of Education for sponsoring this lecture. We've had good times in the past, and we're going to have a good time tonight as well. A couple of years ago, we had Leslie Lemke here that some of you may remember. And Leslie, by the way, is doing well, playing just as viciously and voraciously as ever. And last year, we had Taylor Crow and his father. And this year, we're going to talk about an exciting new program here in Fond du Lac. I've had a long interest in association with autism. I remember the first autistic child I ever met. I was standing outside a house where the Department of Psychiatry was housed, and I heard from outside the house. I walked inside, and there was a 11-year-old girl, autistic, mute, beautiful little girl, banging her head like a hammer on this desk. We finally had to give her a helmet, of course, and do some other things, but it was such a vivid picture of the severity that autism can produce. I had some interest in autism because when I was in training in medical school, we were visited by Dr. Leo Kanner. Dr. Leo Kanner is the godfather of autism. Dr. Kanner was at Johns Hopkins, and in 1943, he described a condition he called early infantile autism, which is where the term autism came from, and it was the first description of this disorder. Most people in the field aren't as old as I am, so they haven't met Dr. Kanner, but I consider myself privileged. He was a gentleman and just a very caring clinician. Dr. Kanner said that in his 30 years of practice, he probably saw 20,000 patients, and he said about 150 of those perhaps had autism. Well, that's a far cry from 1 in 50 that we talk about today. After finishing medical school and residency, I then developed the children's unit at Winnebago Mental Health Institute, where we put together a unit for autistic kids, and that's where I met my savants, and a lot of my work since then has been with savant syndrome, but savant syndrome and autism are very closely tied together. So I've maintained my interest in autism. Now, we could spend the whole night here deciding whether autism is more frequent than it used to be, but that's not why we're here. Suffice it to say that there does seem to be an increase in the cases of autism, but it's not at an epidemic level. When you saw the 1 in 50 figure a couple of weeks ago, you have to understand that that was a telephone survey to which 21% of people responded, many of whom were parents of autistic kids. So if you're going to do a survey of how prevalent is autism, you're going to have clinicians see that child and make that diagnosis. Not the school, not the other agencies, but we're going to have to look at that individual face to face and come to some conclusion, because that's what they do in Norway, that's what they do in Sweden, and their incidence of autism is lower because they're much more finite about what they call autism. Part of the reason why we are seeing this figure, first 1 in 88 and now 1 in 50, is because we keep reclassifying diseases. Many of those patients formerly were called mentally retarded or schizophrenic. I remember patients at Winnebago that we had a diagnosis of schizophrenic who were really adult autistic individuals. So that accounts for some of the increase. And then we keep expanding the diagnosis. Now it's autistic spectrum disorder, to where I think we've lost the specificity. It's interesting that Dr. Kanner himself said that surely there are more cases of autism than I have seen. But he said he's concerned that at some point the diagnosis might lose its specificity to where we will be calling people autistic who in fact have other disorders. So he was right on both counts. As I said, if you look at different countries, the prevalence of autism varies. In the United States, it's about 66 per 10,000. If you look at China, it's about 16 per 10,000. If you look at Israel, it's 10 per 10,000. So if you have that wide a variation in the same condition, we're not calling that condition in a uniform fashion. But that's not what we came to talk about, but I wanted to go on record as saying that we have to be careful when we talk about the incidents. Of course, if you watch the newspapers, or now it says 1 out of every 3 people who die have Alzheimer's. And I don't know, about 1 out of 20 have this and 1 out of 8 have that. And if we all had all the things that each of us would have had, we'd all have multiple diseases. There'd be no way that we could be healthy because there's all these things that 1 out of 10 people have. But what we did come to hear was about this new program starting at Agnesian through the leadership of Dr. Matt Dahl. Now, Matt and I have been associated with each other in doing some research because I know Dr. Dahl has seen many, maybe not 20,000 youngsters yet, but many. And I was impressed with his ability, and my research interest in autism led me to him and to use some of the data that he has and that we are now collecting. So we were working together in a research capacity, and we'll continue to do that now. And as I observed him at work, it just seemed to me that while they already were doing some evaluations and treatment, wouldn't it be nice if there was a facility here in our community that could provide an evaluation without a long waiting list? Currently, if you want to have your child seen in Madison or Milwaukee, there's a waiting list of 6 to 9 months. And if we're talking about early intervention, that sort of is the opposite of early intervention, if you can't even get the child seen for treatment. I was concerned that the diagnosis of autism was being used too loosely, and we have to be careful when we use that term. And I was concerned also that reports from parents were that they do get the evaluation, but there's very little follow-up. You get the evaluation and are sent, you'll see you in a year, come back and tell us how you're doing. That's not what parents are looking for. They're looking not so much for the name, but they're looking for what can I do? What shall we do? What's helpful? So a program that is prompt, a program that is accurate, and a program that's helpful with parents in follow-up is really what I think ought to be embodied in a good autism evaluation program. And that's what has been put together, as you'll hear about as Matt and his staff describe what they're doing. I'm not going to be seeing patients individually myself. I'm tempted, but I think I'll leave my caduceus and white coat to past history for. I just don't want to be on call anymore, is the real truth. But I will be continuing to follow the research programs based on the data already collected and more that will be collected, looking at causes, looking at effective treatment, looking at questions about the age of the father, for example, which seems to be an important issue. Is it or isn't it? And other environmental factors. So I will be there sort of behind the scenes. Let me close by saying something many of you heard me say many times, is that the beginning of wisdom is to call things by their right names. In medicine, if we are going to discover the cause of a condition, and if we're going to find effective treatments, we have to be sure what that condition is. We have to give it the right name. Presently, autism is a collection of disorders, not a single disorder. Speech and language problems, various kinds of other difficulties. And if we lump those all together and look for a cause, we're not going to find one. It's like mental retardation is a final common path. But there are probably 100 causes of mental retardation. And some person some years ago made the observation about phenylalanine. Children who had that deficiency grew up mentally retarded. But if you gave them a special diet, they didn't. And so every baby that's born now has a diaper test to see whether they have that condition. Well, that's one of the mental retardations. And we have a specific treatment now to prevent that. And if we're going to do that in autism, we're going to have to call it by its right name. Now, I know many parents don't like labels, and they don't like their child being labeled, and I'm not using it in that sense, but I'm saying from a research point of view. And so I hope that some of what we can do, in addition to provide the kind of treatment that's prompt and accurate and helpful, is to do some research as well. And that'll be my role in the program. I'm behind the scenes, but I've been very proud to see what has come forth and look forward to many years of productive care from this program. Matt will take over at this point.
Thank you very much, Dr. Treffert. I'd like to take this opportunity to introduce some of our colleagues. For those of you that know about providing care, probably the number one and most important person, but often underestimated and respected, is the first person to take the call. So if Megan could please stand up and just be acknowledged. You don't have to say anything. Sorry, Megan. She's done an outstanding job in gathering a lot of information for us. We are always open to more information. We hope to continue to partner with everybody to make the services that we provide the absolutely best that we can. Megan's also going to be doing some follow-up calls, and we're looking to understand all of the things, including insurances and everything else we can do to help. And so we really appreciate all the work she's done. She's also attending UW Oshkosh to get a certificate in autism, which is one of the ones that the state really validates. We also have Dr. Teresa Davenport, who's been with us for a little over a year now, but has some outstanding experience and came from University of Illinois, where she was working with a lot of students on the spectrum, helping with adjustment to college, and has specific training as not only a line therapist, as a school psychologist, but also with the tools that she uses to evaluate, and she'll tell us a little bit more about that. Dr. Sarah Arnold, my colleague for many years, has a real gift for kind of what they say in the community of autism of getting it. She's genuine, she does an outstanding job, and she'll be sharing some treatment ideas with us and some of the things that she does that some hopefully show and tell in a little bit. We also have Jan Martin, occupational therapist expert. She was a little reluctant to put the years of experience up there, but it helped the team bump our numbers a bit. And we didn't cheat and put Dr. Treffert on there, but that would have been really cool. Jan does a lot of great work with kids on the spectrum and sensory issues and other things, and we'll be hearing from her on her expertise. And Renee has done an outstanding job in the community and has a lot of experience working with children in speech and language. So we'll be hearing from all of us in kind of a panel format. We'd like to ask you to hold your questions to the end, and we're going to try to save some time. There's a couple microphones on either side, and we hope to have that dialogue with you. I'll also be putting up a slide that shows on May 1st, it's a Wednesday at around 5 o'clock at our clinic, 40 Camelot Drive. I don't think we can accommodate everyone, but if there are parents or other folks that have some ideas about how to improve services or our needs in our community, we'd love to have that opportunity to have that conversation. So we're kind of holding that opportunity for us to come and visit with us. So what we've done is essentially capitalized on resources. It's really amazing to me to be sitting here with some of the Sisters of St. Agnes in a facility that essentially was created by the sisters for education, and working at a facility from the sisters, the Congregation of St. Agnes, at a hospital that has a mission that's consistent with what we want to do, which is really to make a difference in the world. And to think back to the sisters and those seeds that they planted into this now is quite amazing. So thank you, sisters. Thank you very much for all of the work and sacrifice throughout the generations. But we also want to provide a service, and that's where we're committed, to try to provide the best service that we can. We have been evaluating, as Dr. Treffert said, for quite some time, and so it is an honor to work with my colleagues here, as well as all of the colleagues that we have at Agnesian. We have some outstanding physicians. We have occupational therapy, physical therapy, both our psychologists, PhD, PsyD, and audiology. Oftentimes there's issues related to auditory processing that we need to look into. We have a Dr. Foster at our sleep center. Oftentimes disturbed sleep can be a contributing factor. I talked with the director of dietary services today, and we have that resource as well. So we're bringing together the resources that we need and identifying how we can be of best service to the clients that we work with. As Dr. Treffert mentioned, we all have an interest in improving, and so mine in particular, and I'm sure I drive everybody crazy, is research and trying to collect data. But that's really how we're trying to design the clinic, is to gather information so that we can make informed decisions both diagnostically and treatment-wise. And we're really fortunate to have that opportunity. So I mentioned within the system Agnesian, but we also coordinate externally with anybody that we need to partner with to provide the best services. That includes our friends at Birth to Three, who've been very helpful in organizing us and helping us to work through what would be most helpful to the families that they work with. Department of Community Programs in terms of resources for intensive services and vouchers, and just anybody that we can think of. I know we have an outstanding school district. We also work with outlying schools. We have some intensive in-home providers. We have relationships with people that it really is about that, trying to figure out how do we put together the best plan to help identify early as we can and make a difference. I won't have to review this very much because I do want to have a chance to hear the rest of the panel. I'm really thankful I went with the 1 out of 88 instead of the 1 out of 50 after listening to Dr. Treffert. That was the most recent data from the Center for Disease Control. But it does matter in what kind of research is conducted. And so we see a lot of information on the internet, and oftentimes it is not accurate information. So we have to be good consumers of information, and we really have to think about how that data is presented to us. The disorder oftentimes is thought of beginning before age of 3 and traditionally considered persistent deficits in everyday social communication and behavioral functioning. It wasn't a typo that I put 4 in parentheses out of 5 because it really depends on which study you look at in terms of prevalence for boys versus girls. The information I have on the slides will not be read to you, I promise. What we want to do is to give you some resources. There's a few folks in the audiences that are taking this for credit, so we wanted to make sure that we had enough data for them. So this is just a little bit about what we think we know right now, and this really changes. So there seems to be some subtypes that we want to keep paying attention to, whether it was an early onset or a regressive, meaning that we had a level of functioning that seemed to be normative for a period of time, and then we begin to lose that. We're not really sure about cause versus result. We see, overwiring and underwiring, but we're not sure what the underlying process is, if that is, causal or not. There is some question about the immune system and its response, but really all of the good science has not indicated that any vaccinations are a cause. Even the most recent study has been on multiple vaccines, and these are pretty tight research things. I know it can be related, and some people are very passionate about what they see, and I think our parents are our experts. 70 to 80% of the parents are correct when they say, I sensed that there was something wrong. So we need to listen to that. But from a research standpoint, it hasn't been supported. And so we really want to make sure parents follow their physicians, work with them, and get vaccinated in an appropriate way. It used to be a thought that emotions weren't really, if you had emotions, then you didn't qualify for the diagnosis. And those of us that have looked in the eyes and worked with our children have very clearly understood that that's really far from the truth. This is about communicating, about connecting, about figuring out how to get those pathways to work so we can connect. It's not an absence of emotions. There are a variety of genes that have been cited, and it's thought to be about 15 to 20% of the cases. And those are the ones we really want to keep an eye on, because if there's a familiar history, that would be an at-risk population, so we really want to get on some of that early screening. So in summary, genetic vulnerability, environmental influence. I'm going to go into some of the suspected causes with a caution. A lot of moms took a lot of hits over the years for believing they were the refrigerator moms, the cause of autism, so much so that the children were removed from their care. Anytime you put this up, parents being parents want to be clear about what happened, how it happened, what can I do to fix it. So I'm going to present this, but I want you to be cautious in how you receive it. These are suspected causes because we want to understand the process. It's not meant to be an indictment on any of your behavior, pre, post, or anything with regards to your children, the pregnancy, or variables that are outside of your control. But it's hard for us to sometimes take that information in without feeling personally responsible. So right now what we have are kind of suspects. As Dr. Treffert mentioned, advanced age of fathers, sperm degradation, one of the things that had been kind of understood in terms of women, but not necessarily thought of as in men. And so we're gathering more data. We don't know for sure, but these are our research lines that we're working on. Low birth weight, deficiency in folic acid before conception, exposure to pesticides, air pollution. The Center for Disease Control does some kind of difficult work. They gather up people that have recently died, and they look at what's inside their bodies. If you look at that graph of what's inside there, it's more and more contamination over time. And so the question is, how do our bodies handle that? And what kinds of things might happen to some genetics because of that? And then obesity and another category. So along with that last caution, one more, early assessment. I have not the personal experience, but my analogy comes to mind, is that you're at your doctor, you're a woman, and they say, well, that lump seems a little suspicious. We'll tuck you in 6 weeks to take a look at that. And then you get your result, and you have to wait for a feedback session for a while. That's the kind of anxiety, I think, that you think there's something wrong, but you don't know where to go and how to get it. So we really looked at what could we do in our community to be the most effective. How could we help? And one of the things that came back was the waiting lists for assessments. And so we have the team, we put it together, and we want to be as timely and efficient as we can to really help get a clear diagnosis of what we believe to be going on. Sometimes we can't, and Dr. Teresa will talk a little bit about that. But we really want to try to get that information to the family and try to get some interventions moving as quickly as possible. The benefits of early assessment are kind of clearly defined, but one of the exciting things that I just wanted to point out to you is that now that we can see how the brain works, it seems that suddenly what we kind of intuitively knew is valid, right? And so what we know is that we can actually change neural pathways, and we can help with some of those over and under connecting, not maybe all of them, but some of them, if we can start early when development is first occurring. How do we engage? How do we help with some of those over or under connections? And so we actually do see some changes in the brain. As a psychologist, that's kind of exciting, because as a talk therapist, my brothers always tease me that I'm in a pseudoscience. It's not a real science. But it's nice when you see that the medical evidence supports that neurology does change based on environmental experience, and that includes us, but more importantly, the parents and the home environment. And that means we can do things differently and actually have a significant impact. The question about the suspects, and I don't know if any of you are old enough to remember the Casablanca, but that was my illusion. The usual suspects. We look at things, and we really have to recognize that both verbal and nonverbal communication is part of what might be going on, both expressive and receptive channels, the pragmatic, the use of language, and then oftentimes we see comorbid disorders. One of the ones I left off with probably would be present in my mind at the moment is a lot of anxiety. A lot of children have a lot of anxieties or fears of things that they seem to respond to. I have a young man that we were working with, and he was afraid of bees. Bees and bicycle riding are a couple of common things that come through, right? That whole balance thing. And so, I came up with, as a psychologist, this great idea. Okay, we'll do some exposures. We'll do your belly breathing, we'll calm you down, and we'll go to do some bees, right? So we do some bees, that's pretty cool, and he calms himself down. And then we decided to do the exposure with YouTube, because YouTube's great, right? And so he's watching all these bee things, and we're kind of like into bees, and he leaves, and he's like, "I'm cured, Mom. I'm good. It's all over. All done. Don't have to do that anymore. Dr. Matt cured me." Like, wow, that's pretty clever. I don't think he was cured, but it was a good idea. He doesn't have to come back and do that anymore. He'll be all right. So it's really a dance between anxiety and self-preservation and understanding a lot of different factors. Tourette's, TS, is a loop, right? Vocal motor tics combined. ADHD, that attention and concentration, the ability to stay focused, the movements that go along with that. If we think about OCD, it's another loop, right? Where you get stuck in the thought that you have to behave in a certain way, otherwise bad things will happen and anxiety rises. So you begin to see some of these symptoms that are clustered together, and there's some thought that they all work in the same brain area, the basal ganglia. But that's really what we're looking at is, there's sometimes an ish, it's a little bit of this, a little bit of that, a little bit of that, a little bit. And so we really need to pull those apart and understand them as best as we can to be effective. The hyperlexia and savant with Dr. Treffert in the audience, I'm not even going to try, but his area of expertise, children that read early, that may be significantly early, may be related to autism, but sometimes not. And to differentiate that for parents, what a relief to know that that course and that trajectory isn't what maybe they feared, and to know that as soon as possible. Savants, skills, focusing on abilities. One of the things that medicine oftentimes comes at as a deficit model. There's something broken. And really, when we think about treatment and how we want to work, it's bringing forth the strength. And so that's really where I think we want to focus on ability. So if there's a special interest, if there's something that we can do to connect, that's where we would like to go. genetic factors and some of these other things that we just talked about. I'm sorry, I skipped the slide, but that's just so you know, in our community, in our county, using the 1 out of 88 data from our slides, that's about the number of children, total population, all the kids that we think might be impacted. And we really wanted to kind of talk a little bit about listening to other kids. Now, I have a little bit of a stretch exercise. I'm not sure why it was suggested that a stretch exercise would occur after I just talked, but they felt the audience may be a little sluggish. So, the other part of this is that, honestly, we all work with children, and it really is kind of anxiety-provoking to have a bunch of adults in the room. So, being that we like to play, we're going to try this for a little bit. And I really think that play will be part of what we talk about in terms of, yeah, you guys can go on up and hit the back seat. We don't have a T-shirt gun or anything. No cool toys. I just want you to think about, how did you know how to do that? And you're right. Some of you may have had some strong reactions and avoidance and provoked anxiety that this ball's flying around at you, where others of you may have thought this is kind of fun. But think about the world from that perspective. And one of the things I wanted to kind of explain is that there's this getting it or not getting it. And to understand that there was a lot of relationship, there's a lot of working together, there's about the game and keeping it in the air or not. There's all kinds of depth that we can talk about with that. The interest of time and my colleague's expertise, I'm not going to go there, but Dr. Treffert mentioned the head banging. There's a gentleman that did not have language that later developed language, and he explained the reason he hit his hand was he didn't know he had a hand unless it hit something. And to be in a body where the circuitry is wired in such a way that you don't really know where you begin and end, and what might that be like? And that's really what we're trying to do, is trying to understand that individual, how their connections work or don't work, are overwired in sense of the greatest amount of alarm for sounds that just would drive you nuts, to ones that we wouldn't even notice. And so at that point, I will leave it over to my colleague, Dr. Davenport. You got one?
And I think if anybody wants a beach ball, I think you can come up at the end and have a beach ball. My name is Dr. Davenport, and I was first introduced to autism working in a residential facility when I was an undergrad. And so these were kids whose behavior problems were so bad that they couldn't be in their home anymore, or in their typical school where they would normally be. And I just fell in love with those kids. It was so much fun working with them, even with their behavior problems. It was awesome. So then when I went to grad school, I went to school psychology, which you can kind of think of school psych as assessment psychology. So I really focused on testing and assessment. And I continued to work with autism, and I got some specialized training in diagnosing autism. Then did my dissertation. We did a summer camp for kids with autism. So it's often a gap is the summer months when there's no one to teach them. They're not at school, and so we tried to fill that gap. So I got a lot of experience doing that, and that was great. And then, as previously mentioned, I went to the University of Illinois to do my postdoctoral work, and got the privilege of working with individuals who are much higher on the functioning level, who are enrolled at the University of Illinois, and getting to see their experiences and help them be successful in the classroom, and that was a real treat as well. So I've gotten to see the whole spectrum and work with individuals from the entire range, and that's been a really great experience. So when I heard about the opportunity to come here and work with these fine people and offer these services to the community, I couldn't resist that. So that's why I'm here. So I'll be talking about the assessment portion of, which button do I, that one? Okay. So I'll be leading up the assessment team at the clinic and doing a lot of the testing. I wanted to start talking about when can you first start seeing signs of autism, as we were talking about how early can you. There's been a number of studies that have looked at this. We would like to identify it as early as possible, right? And the idea going back to early intervention, starting right away. There is no, just like kids with autism are all very different, there's no single sign in an infant or a baby that they're going to go on and develop autism. There's no clear sign. When we looked back, we've done studies where, for example, we look at old videotapes of parents of children who've been diagnosed, and we look back, now that everybody's got an iPhone and cameras, we can look back and see what were their symptoms like when they were a very young child, and what did we see. And we're starting to see some commonalities. Again, I want to share the caution. You know, if you see one of these things or two of these things, it doesn't mean, my child has autism. You know, but these are some commonalities just to keep an eye for. So we talked about being a very passive temperament, not being very engaging, maybe not smiling back, easily irritated, going back to that sensory stuff that we'll talk about. Some kids can't tolerate, you know, onesies or the zippers up here, or, you know, diapers even, those kinds of things. So are they really sensitive to those kinds of things? The one thing that comes up frequently is failing to respond to their name. So if you call their name and they don't respond back, that's been one that's clearly differentiated children who go on to develop autism and not. Again, it's not 100%, but that's been one that's commonly been found. So I just wanted to throw up some of these ideas to keep an eye out for. If you see these, this would be the kind of thing to say, give us a call and say, you know, maybe let's start a relationship, start the process, and these are what I see, can I talk to you? And come on in and we'll talk about what you see. As you get older, we see more of the social deficits come into play. Often we see the speech deficits come. If there's a speech deficit, about a year or two, we start to see that in the social deficits, not looking at people, not wanting to play with peers. And you'll see some of the restricted and the repetitive behaviors. So some kids will rub on certain things, or they'll want to do a certain movement over and over again. They'll flap their hands, that kind of thing. We start to see that as they get a little older. You know, really, as I go back to what I was saying, you know, we don't want to do a wait and see. You know, same thing as Dr. Treffert was saying. We don't want to say, we'll come back in a year. You know, that's why I say, give us a call. Let's come in and we'll talk about it. We can always do some rating scales. We can see where things go and keep an eye on things. Give you some ideas of what you can do early on. You know, so these are some things to look for, and we want to get the services as soon as possible. So what are those? What do we do for an assessment? We look at the whole approach. Everything is included. So the first thing we do is interview the parents, right? Parents are experts. You guys know your kids better than anybody. So the first thing is we talk with you guys, do an intake. We want to collect any evaluations and reports that you've already had. We try to get this ahead of time so that I can review it and talk about it, so that I know and I don't have to repeat all these questions or sit there and read in front of you, you know, so I can get it ahead of time and get an idea of what's going on. And so we have something to talk about. So we try to collect that right away. The gold standard, the test that I use, is the Autism Diagnostic Observation Schedule, and it's actually currently the 2nd edition. And I'll talk a little bit more about that. That's a play-based assessment. It's designed to, and it goes all the way up to adulthood. And I was going to bring, I got scolded for not bringing my toys. But really, it's a play-based assessment. Kids come in, it's all set up, we're ready to go. And we're trying to elicit social interaction and social deficits that would be consistent with autism. So, for example, we'll have like a birthday party for a baby doll and see, you know, will they, you know, show an interest in the baby doll? Will they feed it? You know, will they give it a drink? And we give certain prompts as we go through. We try to call their name and see if they'll respond, things like that. But the kids don't even know they're being tested because they're just playing. So it's a super fun assessment to do. And so that's kind of the gold standard. That's how we would measure that. We look for those symptoms in session. I'm not just going on what I hear or because I gave somebody a rating scale and say, oh no, you've got autism because somebody said that on a rating scale. I'm looking for it with the child as I play one-on-one with them. For younger kids, parents, I'd love to have parents stay in the room so you guys are part of the assessment. For older kids, that's usually not as much as important, but for the younger kids, you're part of it. Again, you're the experts, so we want you in there too. As I mentioned, we also do the behavior checklist, especially for the younger kids. But part of why we use that too is because it's easy to get opinions from teachers and other caretakers and other people involved. So again, looking at not just parents, but looking at as many data sources as possible to make our diagnosis. So we'll use those, a lot of those. And then the behavioral observations. So what am I seeing before? What am I seeing after? After we're done with our assessments, maybe we'll just play and hang out for a little bit. And what do I see there? Am I seeing different things? Are we seeing anxiety? Are we seeing other things? So I can look for other parts, other things there, other pieces of the puzzle. So what's the process if you have a concern or you get referred to our clinic and to our services? You'll call, and our wonderful trained secretary will do some intake with you and ask you some questions, again, to get an idea of, what are we going to need to do? And then you'll have an intake with a psychologist, typically me, although that may involve my colleagues here. And we do a long intake going from birth all the way through. Tell me about your child. What happened? What do you see? What skills do they have? Because everybody's unique, so we want to get that unique picture and know what's going on in the family, all of that. So you do an intake. If testing is recommended, if I hear enough things and I'm thinking, yeah, I think we should do a full autism assessment, or maybe we should just look at this or something. If we decide, yeah, let's do the assessment, we'll schedule the assessment usually on a Friday. And I set that up. I'd like to be able to do really an untimed kind of session so we can go at the child's pace. So some kids need some time to adjust, and get used to a new environment. And sometimes we need to take a break and give the child a little bit of a break and then resume testing. So by doing that on a Friday, we have that flexibility rather than saying come for this hour or 2 hours slot and we better get it in that window. We've got that flexibility. So usually on a Friday is what we would do. And in that process, I would invite my colleagues to do the speech and the OT evals if that's needed and if that's not been done or if we want to update that. And the idea is that they would come, in addition with that. So right there, everybody's in one place for you. So that would be the process. And then we give you a formal feedback after. I'll write up everything in a report, usually 2 to 4 weeks after, call you back, and go through everything we did, everything we saw, explain the results fully to you. Evaluations are comprehensive. As I mentioned, we can add the other services as needed. Really, it's based on the child's age and what I think needs to be assessed, or what we think needs to be assessed. For some kids, we can rule out maybe they've had an IQ test or a cognitive test at school already, and we don't need to repeat that. We don't need to put the kid through that again, Or maybe, we're wondering and we need to rule it out, so maybe we'll give that. Maybe we'll just give a portion, So it's really based on what we think as we go along that the child needs and what we need to look for. So it's really, based on the child's needs and what your guys' needs are. And it's conducted one-on-one. As I mentioned, it's primarily play-based, and you're able to stay in the room for younger kids. Even most of the other assessments are also play-based, and they're one-on-one. So this isn't the test that you'd get set in a room with bubble sheet and, alone. It's a one-on-one interaction. So like I said, I give a written report. I truly try to write, in line with what everybody's saying, I try to write reports in easy-to-understand, fashion. It was always my pet peeve when I was going through grad school that we'd get these reports, typically from neuropsychologists, with big, long, fancy words that made no sense to anyone who read them. And they looked impressive. They were 30 pages, and they, looked very impressive, but no, they didn't mean anything to anybody. And I want it to mean something. I want it to be useful. So I try to write up a narrative of exactly what I see in a way that you can follow and understand. And then I put all the scores at the end and stuff so you can look at and review all of that. And then I try to give a resource packet with services for everything that, like in-home therapy, resources for Social Security, all of that stuff, so that you walk out, if you get a diagnosis, you walk out with everything that you would need, right there. And who to contact and all the information right there. So you don't have to go find it. So last thing, like we said, we don't want to say, oh, you have this diagnosis, good luck, go figure it out. We want to help you connect to services and make that bridge to the next step. And then we want to follow up after that. At like 3 months, 9 months, 15 months is what we're hoping to have one of us contact you to see how things are going and see what we can do. Of course, you're always welcome to contact us if you have a question or a concern too. But we want to deliberately reach out at least 3 more times after an eval. The recommendations that I'll make are, again, customized, just like the eval. So they're based on what I see and what I think the family needs, what the child needs. And I try to actually give examples of what a parent can do at home. So not just saying, oh, go see, this person or that person, but here's a game you could play with your child that, I noticed when we were playing, they really liked this. They really liked tickling. So here's a game based on tickling that you can do to help your child interact. And I want to give some tips for parents so they can leave the office with a report with some idea of what can I do now to avoid that anxiety that we talked about, like, oh, what do I do now? I got to wait for therapy services. Here's something you can do right away. And I know Dr. Sherrill will give some more ideas on that too. And I'll hand it over now to Renee Allen, speech therapist. So that's you.
Thank you. I think I need a clicker.
Clicker up.
As part of my role with this team is obviously to conduct the speech and language assessment. And like Teresa's evaluation, it is primarily play-based. It's fun. We try to elicit as many skills as we can. But, I also understand that after undergoing Teresa's evaluation, the child may not be really ready to play again or might be tired. And so oftentimes we have to just base some of the skills on the parent's report. But I really try to get as much interaction out of the child as possible. And really the goal of the assessment for the speech and language portion is to just determine where the child is functioning with their communication skills. The standardized tests that I administer, that's a great way for me to compare a child's performance with their peers. It's important information to know, however, it's not the most important information. I really find that what parents can share with me or the behaviors that I observe, just like Teresa, those are the things that are going to help guide my treatment plan also for the child if we decide that treatment is recommended. If the parent tells me that their son doesn't like to be touched or they don't like their hands held, that will give me a cue that maybe sign language won't be the mode of communication for that child. Maybe we want to look at a picture communication system or another gestural form. So it's really helpful to have parents in the room, and they are our experts. And I find if I can establish a really good relationship with the parents right from the get-go and establish that comfort level, that will help us down the road because I need them on my side. I really need their trust, and I need us to be a team. I'm only with the child an hour a week. Sometimes that's usually the typical recommendation for speech therapy on an outpatient basis. And so I really need the parents to be following through with any of the strategies that we recommend. So, and I enjoy that part. I really enjoy getting to know families and becoming a part of their life. Let's see. Whoop. So again, those are some of the ways that we assess a child's communication skills. There we go. Speech-language pathologists are really primarily focused on assessing all those areas and then some, but for the purposes of the autism communication team, these are the primary areas that I'll be looking at. If the child is not yet verbal, not talking yet, obviously I won't evaluate any speech sounds, but I do want to assess his understanding and use of language. And really the functionality of his communicative attempts. So, what is he doing now to get his needs met? Is he pointing? Is he leading? Is he pushing? Is he, shaking his head no? What is he doing for facial expressions, body movements? How do we know what this child wants? And so I'll ask parents, do they seem to understand routines that you have during the day? When you say, okay, it's time for bath, does the child turn and look? Do they come to you? Do they run to the bathroom? Or do they continue to play with what they were playing with or continue to be involved in whatever activity they're doing? Do they seem to understand the flow of the day? How are those transitions? Does it cause a meltdown if you say, okay, it's time to eat? Is there a sense of understanding about the day, or are they sort of not really present in that world with you? And I really want to know how the child is having their needs met. When they want a snack, are they going to the kitchen? Are they opening the cupboard? Are they pulling out that granola bar and pushing it in your face? Eat, eat, eat. Is there some sort of intent there or motivation? Or like many children that we see with autism, do they just stand in the kitchen and whine or scream and not know and not have a way to communicate? So, parents are really adept at sharing, all of the ways that their child is able to communicate. And I think as descriptive as they can be, it really helps me. If there are concerns about, the child's ability to hear, we'd want to rule out any sort of hearing loss. If there are concerns about a child's ability to actually process the information that they hear, our audiology clinic is equipped now to conduct screenings to determine whether or not there's an auditory processing disorder, so that's been helpful. Part of my role is to perform a differential diagnosis, and it can be tricky because there are several communication disorders that may look like autism, so it's really important for me to be able to rule those out when helping to make a diagnosis. Nonverbal learning disorder, those children you'll see, they are typically very poor visual learners, and they struggle with interpreting social cues, those nonverbal gestures, eye contact. They tend to not be able to take turns during conversation. They tend to talk excessively. They tend to be sort of excluded from social circles. They have difficulty making friends and then keeping friends. So, but we know that most children on the autism spectrum are very strong visual learners, so that's an indicator for me. Receptive language difficulties will affect a child's ability to respond to questions, follow directions, or remember what has been said to them. And we should really note that all children on the autism spectrum really do have some area of difficulty with receptive language, whether it's a mild issue, maybe you have to touch them often for them to respond, or maybe it's a significant issue where they really don't have a clue what's happening. They're really not responding to their name or directions. They don't seem to understand what you say to them. And then there's a mixed language disorder also, and those children have problems using vocabulary, constructing sentences, as well as understanding concepts and directions. There's also a pragmatic disorder, which most children on the autism spectrum struggle with pragmatics as well. That social communication piece, that's just a hallmark characteristic. And the primary goal of speech therapy for children with autism is to improve that child's spontaneous communication and also their ability to form relationships with the important people in their lives, particularly their parents, siblings, grandparents. We don't have a whole lot of evidence yet to predict which specific approach will be most effective for children with autism, but we do know how important it is to individualize treatment for children. And like I mentioned earlier, we involve family members in the sessions. They are present as much as they want to be, and even if they don't want to be, I think I like to do a nice job of trying to pull them in as best I can. Oh, and one of the first things that we do in therapy is to try to help identify the motivators for the child. If a parent will tell me that, he really only likes puzzles and that's kind of a favorite activity, then you can bet I'm going to be using puzzles during most speech therapy sessions in the beginning to try to enter that child's space, enter their world, gain trust, and I'm going to play like that child. If they're intent on lining up those puzzle pieces, I'm going to line up those puzzle pieces too. And it may seem contradictory, but in the beginning when you're trying to establish a relationship with a child, you really have to do what they're doing. It's key. And then through that relationship, as we get going, I'll be able to pull that child into doing what I want him to do. So follow more adult-directed activities and be more responsive. But in the beginning, I'm really focused on trying to determine what is exciting for the child, what smiles, what brings him smiles, what incites some joy. So really, I think the whole goal is just to equip the child with some communicative strategies, to create some independence, and spontaneous communication, and we really will know that we're successful through speech therapy if that child can use that language in many different environments with many different people. When parents can say, yes, he told grandma he was all done with his snack, or he asked for that movie at the babysitter's house, or at school, he said potty. Those are the things that or going to let us know that we've met our goals and we're on the right track. You know, it's not just what the child's able to do with me in that 45-minute session. It's looking at the big picture. So with that, we'll talk about sensory processing with Jan Martin, OT. Yep.
And one of the biggest differences we have here is, because I have all this experience, my notes are printed much larger than hers, okay? Are you all awake yet? Because if you're not, I'll have you stand up and take a break. Okay, so I am going to talk about sensory. It's a big piece of ASD. And I'm going to just start with some definitions. Sensory integration, first of all, it was coined by, well, I think it was coined anyway by Jean Ayers. This is way back in the 70s, 60s and 70s. And it's the organization of sensation for use. This is the information that tells us not only what we see, or we usually think of 5 senses: seeing, hearing, smelling, tasting, and touching. But also, it's also information about where we're at in space and in relation to gravity. The example, actually, that Matt used about the child that was banging to get information to his body was, you know, write down what I work with, because that child did not have a very good sense of where they were at in space. So that's what we're talking about. And I'm going to use an example several times here tonight. I'm going to start out with just a child in the classroom. If they're sitting there in the classroom, they see the teacher and everything around her. They hear her talking, as well as other miscellaneous sounds from other students, and they maybe smell things. They feel their clothing, the chair they're on. They know where their feet and hands are, and whether they're on the chair or falling off of it. They have a good sense of all that. You have all that right now while you're sitting there. You have a good sense of where you're at in space. All this information, when it works together, is called sensory integration. Sensory modulation is a child's ability to regulate and to manage one's response to that sensory input in a graded and adaptive manner. We sort out all that information and we decide what needs attention and what needs to be ignored. Hopefully you're paying attention to me and not what's happening to anything else in this room. A normal child in the classroom, therefore, will focus on that teacher. They will ignore maybe the colors and the visual distractions that are behind her. They will listen to her, ignore the sounds of the chair scraping, or even the pencil scraping on paper next to them. They will be able to ignore most everyday smells. They will be able to take no thought to what they're wearing, and they will be able to sit on their chair. They won't have any difficulty sitting upright and paying attention. That's what most kids should be able to do. But a child that has sensory processing disorder, which often goes along with ASD, this information goes into the brain but does not get organized into appropriate responses. And that information is either poorly detected, poorly modulated, misinterpreted, and then those atypical responses occur. I think it's important to understand that any child can have sensory processing disorder by itself and not have ASD, but almost all children who have ASD have sensory processing disorder. Sometimes just sensory processing disorder by itself can almost look like ASD and not be that. So that's something that I think we all need to understand. I treat sensory processing disorders, and for that reason I see a lot of children that have autism. So the ASD child is often in a state of sensory disintegration, having extreme patterns of reaction to the sensory input, and that interferes with their learning and function. So tonight, really, I'm just going to talk about sensory processing in autism. So usually it's going to look like either over-responsiveness or under-responsiveness. And there are different categories underneath that. Sensory sensitivity. This is distress and distraction from sensations. These children tend to be very easily distracted. They pay attention to the latest sensation, and it draws them away from whatever they are originally trying to attend to. They are cautious and often resistant about coming into unfamiliar settings because they don't know what sensations are present or what they have missed. Sensation avoiding is controlling the amount and type of sensation input. These children may be disruptive as they try to control it. They may have emotional outbursts to get out of a situation. They may withdraw to get out of it. They may create rituals for their daily lives and get upset if that ritual is interrupted. They may limit sensory input to just those familiar things in their life. Then there's under-responsiveness. What does that look like? Well, there's low registration. That is a low awareness of different sensations. Sometimes these kids appear very uninterested, and they have a kind of a flat affect. They often have low energy levels and act like they're overtired, self-absorbed, apathetic. The theory is that their brain is not getting what it needs in order to generate a response. And then there's sensation seeking. They exhibit interest and pleasure in sensation. These children add sensory input to every experience in daily life. They often move constantly. They make noises while they work. They fidget, rub things, explore things with their skin. They'll rub it on their mouth. They'll rub it under their nose. They'll do all kinds of strange behaviors to us. They chew on things. They wrap their body parts around furniture and people. They're the kind of kid that's going to come up to you and push into you with their head. And sometimes if they're small enough, they'll wrap their legs around you and let you carry them that way for a while. So let's see here where are we at here? I'm in the right place. The impact, right. So let's go back to that school setting that I described earlier. But this time it's a child with ASD who has sensory processing difficulties that's sitting there. Visually, he may be easily distracted by the colors and the bright lights, the pictures, the bulletin boards, the movement of the teacher, so they're not even hearing what she's saying. They're oftentimes distracted by sounds that we don't even hear. Sometimes it's the sounds of the chairs. I had a child one time tell me they cannot focus in the classroom because everybody's scraping on the paper with their pens. They couldn't tolerate it. They were just always on the top of their sensory tolerance with that. Sometimes lights are humming, sounds in the hallways bother them, toilets flushing, echoes in the bathroom. You'll see them often put their hands over their ears because of hearing sensitivities. Smells, they're often distracted by unusual smells, things that we may not even notice, and you'll see them block their nose with their hands or their sleeves. Taste is often an issue, and oral input. They often avoid any new tastes or textures, and they can be rigid in their eating behaviors. When it comes to touch, sometimes they can be distracted by the tag that's in their shirt, the stiff design on the t-shirt, you know, those ones that have the real cool big designs, drive them crazy sometimes. So they're telling mom in the morning, I don't want to wear that shirt. I can't stand that shirt. The feeling of certain fabrics can be very irritating. They refuse sometimes to wear jeans because of the way they feel. They're too stiff. They may get upset when touched unexpectedly, and they can become very aggressive to control people's touch. At home, they often struggle through routine self-care tasks like bathing, brushing their teeth, washing their hair. They will often move to get a sense of where they're at in space, going back to that banging, the rocking. That's what it looks like. Sliding off the chair sometimes and then getting back on it. Skipping or running inappropriately because they've got some space to do it, or they don't want to touch the people that are in the hallway anyway. Spinning themselves often occurs. They often seek pressure through pushing and hitting and biting, climbing on and off furniture. You may often find them sitting in a corner curled up in a ball because they're so overwhelmed with things. Because of the child's focus on all that sensory seeking and or avoiding, which often occurs in the child, often both over-responsiveness and under-responsiveness will occur in the same child, and they'll be either avoiding things or seeking things. And often that accounts for some of those crazy behaviors we see that we just can't understand, and that interrupts with basic function in the classroom, in the home, when you're interacting with other people. It's just a big factor for them. Change? Oh, there it goes. So a child who then has ASD, along with sensory processing difficulties, is likely to present with constant movement, inability to sit still or attend, rocking or spinning, fear of movement, seeking to touch everything, avoiding the touch of others. Again, there's that seeking and avoiding together. clumsiness due to poor awareness of body and space, oversensitivity to sounds, lights, smells, tastes, poor eye contact, easily overstimulated, unexplained meltdowns due to the sensory input often that we are even unaware of because we're managing it or integrated. So the tools that I will use, there's 3 primary tools that I will use when I'm doing these evaluations. I'm going to use the short sensory profile because it is a standardized checklist. It indicates areas of difficulty in sensory processing. It is completed by the parent, but it is in comparison with other children of the same age. If the child's 3.5 or younger, I will use the infant-toddler sensory profile. I also use the listening with the whole body questionnaire, and that's a long name for a big long checklist. But that gives me a lot of good non-standardized questionnaire questions that allow me to gain more anecdotal information about the child. It's concerning their difficulties not only right now, but in the past. It gives me some of that information about when they were a baby. Did they tolerate being cuddled? Did you have to rock them and rock them and rock them and rock them to get to calm down before they go to sleep? I also use the Pediatric Evaluation of Disabilities Inventory. This is a standardized functional checklist for self-help skills that tells me what areas of function in the sensory processing disorder, what is affected, and that gives me really good functional goals then to work toward. I may also evaluate the child's fine motor skills, visual motor, perceptual motor skills, and all that just depends entirely on the child's attention span. If the child can't communicate with me or they cannot follow simple directions, then I'm going to rely more on those first 3 primary tools. And then most of all, I depend on my observations. When I see a child in a clinic area, I'm going to look how they react to different pieces of equipment that are going to be there. Are they gravitated toward a swing, and do they spin themselves over and over and over again, and they stand up and walk away in a straight line? It's incredible. But they do it because they crave that movement. Their body, their vestibular system is craving that movement, and so they're going to get it in whatever way. Sometimes they get on it and they say, just swing me hard, back and forth, don't spin me. And I'll go as hard as I can, and they love it, and they'll be on there for a half an hour if I let them. Sometimes they just want to crawl into someplace dark. You know, I look at their responses to what's there. I look at what makes them smile. When I start to get a child that comes in and they're kind of shut down, they have that flat affect, and they're coming down with it. They come down the hallway and I see their shoulders are slumped and they're scared to death and they don't want to do anything. And they come into my room and they see what I have, and then they just light up. It's awesome. I love it. There we go. So, in summary, all children do have sensory experience at times that they don't like, but they're able to respond or adjust without frequent extreme reactions. Children with ASD tend to have extreme reactions of avoiding or seeking stimulation due to their inability to adapt, adjust, or self-regulate. And then our treatment, that primarily the thing that I do was to calm that sensory system. I'm going to use therapeutic brushing, proprioceptive input, which is a fancy name for heavy work, vestibular input, which is a fancy name for movement, tactile exploration, oral motor tools, and therapeutic listening. Once I begin treatment, the child quickly learns that much of the therapy is focused on calming and alerting, and they enjoy the treatment because it meets their needs. I also educate the parents, and if the child's old enough, I'm talking to the child about what they need to do when they get in tough situations when their sensory system is overloaded. We develop a sensory diet for them, and that is determined. Each child has their own individual sensory diet, and we determine what is best for them and what they need in the school setting or at home. The parent is encouraged to get different things that can help the child and help them function. So I'm going to now introduce Dr. Sarah Arnold.
Thank you, everybody, for coming. I look around and I just smile at how many people care about kids in our community. This is just wonderful to see so many people here. And as I think about treatment, I think about how we all work together in our community. And it really does take a whole village to raise a child, and especially our children with special needs. So it's wonderful that we have so many people that care about kids. And then I think about treatment, and there's that saying that there's, if you know one child with autism, you know one child with autism. And that's really how treatment is. Everyone that you heard talk tonight said, whether it was assessment, you know, it's individually based. You know, we have to see how it works for that child to make sense. And we heard about OT, and you heard about speech and language. You were hearing how it really is individually tailored to meet that child's needs and your family's needs. And it's the same with treatment. It's really individually tailored. There is no cookbook, and we can't just look at a recipe and say, this child has this symptom, so this will help this child. We really have to get to know the child and understand that child's strengths and how we can help that child best. And what might help that child when they're 3 might look really different for what's going to help that child when they're 6 and 9 and as they develop. So we want to be able to be supportive for the child and your family throughout the lifespan as well. And so we look at symptoms. You know, people say, well, what do you do for treatment for autism? Well, there's lots of things. And sometimes it's not maybe an autistic symptom. Maybe it's one of the comorbid symptoms or a diagnosis that goes along with autism. So maybe it's that the child is really inattentive or has some of those ADHD symptoms. Maybe they're impulsive, and so we're working on helping them self-regulate and help them to have some more self-control. Dr. Matt talked a lot about anxiety, and there's a lot of anxious characteristics that go along with our kiddos on the spectrum. And so maybe it's that we're helping them learn the tools to manage their anxiety in the community, at school, at home. And maybe it's working with their mood, working with sleep struggles, and I could go on and on and on because the list is kind of endless of things that sort of other symptoms that go along with autism. And then I said it takes a village, and so what we do is we coordinate our efforts. And so whether it's that we're working with Birth to 3 or we're working with the school district, or if a child is in intensive in-home, working with their intensive in-home supports. Some children are in intensive in-home treatments 36 hours a week, so really working closely with that therapist can be helpful as well. And then we have the post-intensive services, or for kind of the individual therapy, the family therapy. Again, it's sort of what's needed for that particular family. And then our social skills groups. And you may have seen a flyer. We every summer we do our social skills groups. And this is expanding too. We have typically done them in the summer. So did most of you get these out there? Okay. I've done them typically in the past in the summer, and they've kind of grown to be a really fun thing for our kids in the summer. Last year we had 44 participants that participated in our summer groups, and so they range from ages 4 all the way up into the teenage years, and those are our social skills groups, which I'll talk a little bit more in a minute. Sometimes we're doing peer pairing, where we know of 2 kids that are kind of similar and really could learn some social gains from each other, so we try to match those families up and foster those social interactions. And we talked about occupational therapy and speech and language therapy already, and again, that collaboration. I suppose I should keep up with this, right? There we go. And I'm glad we're flexible thinkers, right? Right. We all know some people who might not be quite as flexible, but that's what we do in treatment. We teach people to be flexible as well. So moving on to some of the therapy tools, this is where I get to do show and tell. And for any of you who know me, I really like to play. So the whole beach ball thing, that was a lot of fun for me. And then I'll move over here. Oh, I better take my sheet along. Or no, that was connected. See, the beach ball thing was really fun, and see if I can get all this working up here. The beach ball thing is fun. We do that a lot, even our social skills groups in the summer. We'll do back and forth conversations. We'll throw the beach ball back and forth and be able to do that. It seems like such a simple thing, but to truly have a back and forth conversation, a back and forth interaction, is really difficult for some kids. So being able to throw a beach ball back and forth, you guys did great with that. It can be a lot of fun. So I am getting... You're wondering what I'm doing. I'm getting the iPad, hopefully, up and running, because we have these fun toys. And so many of our kids really like to like technology. And not only does it have the benefit of having a visual backup, and so many of our kiddos really benefit from having a visual pathway activated. So we can talk and talk and talk and tell them things. And for any of you know, maybe some kids on the spectrum, they can tell you exactly the right thing to do. If you ask them, they can tell you. But sometimes they can't do it. So that's the benefit of having some of the therapeutic interactions, the social skills, and it's the benefit of having some technology, because we can use video modeling to teach them social skills. We can use a lot of things that are sort of motivating on the iPad. So when I think about some of the social skills stuff, I'm just going to do a little bit of a show and tell. Like one of the apps that we'll use, even in our groups in the summer or individually or show our families, is there's one that's called the Social Skill Builder. And so we'll just scroll through and we'll just pick my school day. And maybe we'll pick the jungle gym, a recess situation. And you're having to look carefully at the picture. What do you think you could do on a jungle gym? Play. Jump? I heard climb. Play. All right. Okay. Good job. This is a nice answer, way to go. I don't know if you heard that. And then what it'll do is show videos. And it's going to ask basically the right way and the wrong way. Wasn't that polite of her? Did you hear her say, "Move, please"? Because the next video, she's not saying, "Move, please." All right, what do you think? She asks the girl to move. Such a simple thing. Do you know how many kids that I do this with? And they're stuck. They're really, really stuck. And so this ends up being a really good discussion point. We can sit and talk for much of a therapy hour about turning our body to face someone and the importance of that. Anything else? And she stops. And I won't go on with that. 3 cheers for you, yes. And so there's those. There's the Model Me apps. And for some children, maybe going to the hairdresser is really, really difficult for all the things that we talked about. Maybe it's the sensory piece. Maybe it's the noise, the lights, the touch. Can you hear it? Sorry.
This is the hairdresser. I sit very stealthily. The hairdresser wets my hair. This feels good. He cuts my hair with scissors. Too. Oh, that was easy.
And there's so many more. But the benefit is the predictability piece. Kids might get anxious, and so being able to know what it's going to look like when they're there, being able to see that. You can tell them, you can prepare them, but it's really nice. You know, many of you know about social stories. With our technology, we can go so much further than the paper social story, which in the paper social story is just wonderful as well. But we can do some really fun things that are motivating. We can create social stories that are really individualized, little videos for kids using those things. So some of many of you might be familiar with like the Superflex materials. Just to see if you're all awake, how many of you are familiar with Superflex? Yeah, Yes. So Superflex is this wonderful superhero, and it's really great for kids ages 4 up to about 5th grade, and sometimes a little later, depending, or sometimes they kind of run out of steam at 5th grade. But it's really a superhero, and he is attacking all of these villains, basically. So he has to attack Worry Wall, so that he's not going to worry anymore. And he's going to attack Rock Brain when you get stuck on your ideas. And he's going to attack One-Sided Sid. So he's going to be able to do that. Okay. I was going to use it again, sorry.
Oh, okay, you go right ahead.
I know. I'm really being adaptable and not rigid. I hope that you guys can go with it. So that's some of the Superflex stuff. And so we also will use any of the social stuff that we're teaching, whether it's our Superflex or teaching the social skills. When we do them in groups or individual and family stuff, what's more important than just teaching the skill is being able to apply it and let them practice that and get really good at being confident in practicing that interaction. Because as I said before, they can often tell you exactly what to do. You ask them and they can tell you, but then in that situation, they really struggle. So it's that practical application. I'm going to go to another thing. Sometimes we're teaching kind of the cognitive strategies. And cognitive stuff is just being able to think about things and to think about things differently. And so sometimes we might have someone that gets really anxious, maybe perfectionistic. Maybe they feel like they can't do something. So let me go back to, in our SASH app, we have the shredder. And so maybe they're having to change their thinking about something. And so maybe they have a negative thought of, I have to get it just right. And maybe we're working with them on trying to change that thought process. And so maybe they need to be able to shred that thought. Wouldn't it be nice if we could all shred our worries? Because I know about now, well, I have to look at the time. Oh boy, see, I bet you're all thinking about the million things you have to do on your list when you get home yet tonight. So we'll think, how about just a simple, I can't do it. Okay. Isn't that fun to do? Yeah. You all want this now, right? This one's only $1.99, so yes. So we can shred it. But what we do is we're trying to empower kids to teach that they're in control of their thoughts, that they can control their thoughts and that they can change them. That if they can recognize a negative thought, that's the first step. If they can recognize that it's a negative thought or an anxious thought or a worry thought or whatever we're going to call it for that kiddo, because they make it up themselves. Sometimes they call them yucky thoughts or whatever it might be, that we help them to change that thought and then know that they can do that. The 3D brain is really fun too. To find it on here. 3D brain, this is a free one, and it's fun because kids can twirl the brain around and learn about themselves. And metacognition is really thinking about thinking. So again, kids can learn as they're growing that they can control their thinking. They can think about their own thoughts. So we can show them where their frontal lobe is, or we can show them where their amygdala is. They love to say that word. And our amygdala is our emotion center. And so we can tell them that the brain is kind of working together, and that one part of the brain can talk to another part of the brain, and that they can, again, control their thoughts, control their feelings, and be able to have more power over those things. And then we'll work on, maybe it's relaxation training. Maybe we need to do some of that desensitization that we're talking about and be able to have them handle seeing bees and watching YouTube videos and really be actually able to do that. Then we might be teaching them things like progressive muscle relaxation. We might be teaching them how to do that belly breathing or that diaphragm breathing. And again, I was saying that kids, we often have to access that visual pathway rather than just teaching them. And so there's a neat app. Can't stream the video, no internet connection. Oh, that's okay. We'll just be adaptable again. Part of this one actually shows. There's a guy that actually shows how to breathe. And he will lie down, and he's doing the belly breaths. So kids will get to see how to do the belly breathing. And then they can actually do the breathing along with a video. And so we can, if you see the bar on the left there, to be able to inhale and exhale, and we can make that breath longer or shorter, and we can add music and scenes that are relaxing, and help children to systematically learn how to do some deep breathing. So some of these are the sort of the fun tools that we'll use with when we're doing the iPad. Did I get back to it? Yeah, that's completely fine. If I can go back to this. So I guess in summary is that individually, treatment is really individually tailored. And we try to make it motivating for the kids and meet them where they're at. And it's all, most of the time, very, very activity-based. But I'm going to skip ahead here just to, if I can, I'm sorry.
That's how helpful I was for you.
See, we try to work together.
There you go.
We'll just skip ahead. There's some extra things in here. I want to go to the summary. So I guess our take-home message is what's up here is that we're really here to help. We're understanding that there's individual differences. And there's a multidisciplinary team with a lot of expertise in our community that we're really fortunate to have. And that we're committed to the ongoing research so that we can learn more about exactly what Dr. Treffert was saying. And that everything we do is always strength-based to really enhance that child's strengths and help them to grow based on those strengths. So let's open it up to some questions. And if you don't mind, there's microphones. They're taping this to be available. So if you don't mind, when you do have a question, if you can go to one of the microphones, that would be really helpful.
Or we could get the beach balls back out.
I was just thinking that.
How many questions am I allowed? Our daughter is 17. She was diagnosed as autistic probably 9 years ago. She also has seizure disorder. She's also been diagnosed by one doctor as having a slightly reduced size cerebellum on one side. She's been to KU Med Center. She's been to Mayo Clinic. She's been to Cleveland Clinic. She sees a neurologist at Children's Hospital. Can we give you all those records and then you can put the best treatment plan together?
We could certainly give it our very best shot. You know, one of the things that, as a parent, you're oftentimes almost medical centered out, and it sounds like you have a lot of good data. And it's really, at this point in time, important to look through, see what we have, what we can offer, and have a discussion about the resources and treatments that we're aware of. So I think we are always welcoming to give it a shot, to take a look at what you have, and then if we're not feeling comfortable or not capable, we would certainly let you know that too. So we'd be happy to try to help in any way that we can.
Do you see seizure disorder cause regressive autistic traits?
There's a significant portion of children, unfortunately, that do have autism that also have seizure disorders. And that is not an uncommon presentation in the children that I've worked with.
And do you have anyone on your staff that can look at the seizure meds that she's on and recognize their impacts also on behaviors and such?
Not presently on our staff. We have relationships with Children's. I've worked with, I believe, Dr. Johnson, who's now moved on, but the neurologists down there about medications. And psychiatric care is something that, is really difficult. There is a national shortage in psychiatric care, and that is one of the struggles. But working with neurologists, working with primary care physicians, consulting with child psychiatrists when available are things that we do on a regular basis.
Okay, thank you.
You're welcome. Thank you for the questions. Any other questions?
I have a question about the social skills groups in the summer. Do you screen or look at those groups so you have groups that are at the similar levels of perspective taking, or?
Yes. So the flyer comes out, and the flyer says ages, and then as we get the calls, our dear Megan takes the call and gets a little information. And from that information, sometimes I'll call you back, or Dr. Teresa will call you back and get even more information, because we want to make sure that it makes sense not just based on age, but it makes sense for your child. So we always, we start with ages just to make that the easiest, and then we always let people know when they call that they might actually be put into a different group, or we might actually create an entirely new group based on 4 people that call that really had the same concern that really didn't meet what we had here. So when you call, then we'll kind of, again, individually tailor whatever works for what the need is for your child.
Thank you.
Megan. There are a variety of ways that we try to work with the insurances that we are presented with. Badger Care, I believe at our clinic is, for the assessment is yes. For ongoing services may be a little bit trickier. We have an affiliation and colleagues at the hospital as well, and apparently according to much longer discussion about insurance than we have time for. Being hospital-based versus clinic-based can be a significant difference in coverage. So we have at least, I think, a reasonable idea about ways to work with insurances and families, and at the absolute, bottom line is kind of the, what can we do? Here's what it can be covered. Here's what it can't. Here's where you could go, and it could be covered. We're going to work with the family to make sure you understand all of the options, and to the degree that we understand your insurance, we'll certainly explain that to you as well. Other questions?
Yes. We have a 21-year-old daughter who we kind of went through. She was diagnosed roughly when she was 2 years old, and it was kind of the wait and see. I can see we were given a diagnosis and we were told to come back in a year. So it's great that you have this program initiated here at this time, but as a autistic child gets older, they become it's not as acceptable in society when you go out to different events, etc. And one of the challenges that we as parents face with an older daughter is simple things like going to the doctor, where I don't know what Michelle is thinking, like, well, why am I going here? I feel fine. And we're going for a follow-up. So hopefully you as professionals can be our advocate for parents to the point that we may have to get to the point where medical staff may have to look at doing house calls again when you're dealing with children with autism. So just a suggestion, because tonight most of the information was focused on early childhood and not really approaching as children get older, because, me and my wife, we went through all these different allergy tests, etc., and it got to a point that we had to realize that Michelle was made the way she was for a reason, and we needed to appreciate who she was, love her the way, and try to appreciate her for the blessing that she was, and kind of start to move on. But that doesn't mean that we still don't have challenges, and that's one of the challenges that we face a lot, is the transition. And like, for example, this summer she had a bout with kidney stones, and to the point that she was pushing on her stomach so hard where the kidney stone was that it was bruised. And we drove to the emergency room, and she wouldn't get out of the car. So, that the technology and all that can be great, but sometimes you may have to bring it out right to the home. So, thank you.
Excellent points. And one of the main reasons why that May 1st opportunity was presented to this group, I really respect and appreciate all of the parents that care for wonderful children that oftentimes with invisible disabilities. People don't really see the difficulties or challenges or understand them. And that includes medical staff and professionals like myself through the years. And, you know, Dr. Treffert referenced calling people by a diagnostic name instead of as a person. So there's a lot of work to be done in advocacy and sharing, you know, and developing better programs. There's medical homes right now, which are kind of cool, and that's coming up. There are a variety of opportunities, I think, for the systems that provide care to improve. And so I would really hope if you can make that time to come. If not, I know that I've heard what you've said, and certainly will pass it along and try to think of ways that we can be more helpful. To that end, we do work with children and adults throughout the age span. And you know, we didn't talk a lot about that, and that was one of the cautions about focusing on early intervention, because, you know, throughout the lifespan, one of the most stressful things for parents is not having support themselves. And we really want to make sure the parents here, both from a marital standpoint, from a staying together, financial, all of the things that you do to try to take care of your kids, it's really the airplane model, you know? If you get on an airplane, they tell you to put the oxygen mask on you first and then the kid. You got to take care of yourself. You got to have something there for the children. And oftentimes as adults, we'll sacrifice everything for our children, but we don't take care of ourselves. And so supporting the family, supporting the parents is helping the child. And we really want to make that clear in what we're presenting today, as well as the village. You know, it takes all of us. And so transitioning care to the county, to a home, to other facilities is scary for any parent. And the hope that you would have reached a level of independence that it could have maintained, you know, throughout their lifespan, and you're faced with that. Research is pointing to transition at the departure from your care is the most stressful time for parents, not just the diagnostic period.
And there's that new Fond, is that what you're going to say
Yep,
next?
but you go right ahead.
Fond du Lac, the Fond du Lac area, the parents of children who are going through those transitional things have just started a support group, and it is just starting. And so I don't have any of that along tonight, but certainly you can feel free to call our clinic, and we can get you that information. And yeah, and Dr. Teresa is going to be involved in it. So, so definitely, you know, the services, you're right, go through the lifespan, and there are even support groups that are now available to really make sure that those resources are in place for transitions.
So we've started this little website project, and on that we have resources. And one of the Fox Valley Autism Society, our North Fond du Lac support group, this MAP program through the relationship between the high school and Agnesian. We'd like to serve as a kind of a resource for communities in connecting, but we also know that you've, like you've shared, you've been through so much. And so what resources do you feel that would be helpful to others? Please let us know. Shoot me an email. And certainly feel free to come on May 1st to share any ideas or thoughts you have about improving quality of care and things that we can do.
I think every set of parents also brings to the table, you bring your own experiences. It will help another family that has a younger child and doesn't know what to do, and you have your own experiences that you can help them. I think that's a big piece that sometimes we're always seeking, you know, what we can, how we can make it better for ourselves and for our own child, but your experiences will help others. Don't be afraid to share those.
So I know we're running a little late. Thank you for you guys for being out here, for willing to come, for all of your hard work, for the things that we can learn from you. You know, we really, really appreciate the opportunity. Dr. Treffert, of course, thank you for being our research consultant. Marian for hosting us. And again, all of the hard work that goes into supporting this concert. Dr.
Well, thanks to the panel for their explanation of what it is we're starting, and I think we should give them a round of applause. I'm excited to see the program starting and have pleased to have been a small part of it at least, and I intend to keep involved in that as we move along. Thanks to Marian for hosting this Treffert series of lectures, and Sister Mary Mollison particularly was instrumental in starting that, and I appreciate that. And if you have ideas as to what we might take up next, please let me know. And one of the things we might take up next is what do you do with the child who's out of school? for adult intervention, and certainly there are some interesting programs going on along that line. Some time ago, I recently wrote a paper, and it's called Autistic Disorder 52 Years Later, Some Common Sense Conclusions. I've been looking at this for 52 years now. And if anybody's interested in what my conclusions are 52 years later, you can pick this up. Actually, it's on the Savant Syndrome website, which I maintain at www.savantsyndrome.com. If you go there, you'll see articles on the right menu, and if you push on articles, the fourth from the bottom is this Autism Disorder 52 Years Later, which talks about etiology and treatment and where we've been. And I certainly would invite you to take a look at that if you're interested. I will leave this on the table as tells you how to go about getting that paper. So thank you for coming. I'm so pleased to be able to have as one of the lectures something going on in Fond du Lac of which we can be proud. And I think that we will become, I think, a real in-state resource, not just for this area, not just for Fond du Lac, if we adhere to the prompt and accurate and good recommendations. And as long as I'm looking over their shoulder, that's what we will do. Thank you very much.